Okay. Um,
Evaluation of proptosis, right? Okay.
yes. Okay. Good morning, everyone. Today I am presenting evaluation of proptosis. So, to start with basic terminology, a displacement is common clinical manifestation of an orbital abnormality. It usually results from a tumor, a vascular abnormality, an inflammatory process, or a traumatic event. So, proptosis or exophthalmos is an abnormal forward protrusion of one or both eyeballs with respect to the orbit. A protrusion of about 22 mm beyond the orbital rim and an asymmetry of more than 2 mm between both eyes is considered as proptosis. Exophthalmos is a term used most often to indicate thyroid proptosis associated with thyroid eye disease. Next few terms include dystopia, exorbitism, hypertelorism, and telecanthus. So in dystopia, there is a coronal displacement of the eyeball. That is, the eyeball could be displaced inferiorly, superiorly, medially, or laterally. In exorbitism, what happens is the volume of the orbit is small, because of which the contents which are normal are protruding outside of the orbit. In case of telecanthus versus hypertelorism, as we can see in this picture over here, this X represents the medial canthal distance and the IPD. If we compare this in an orbit, we see a patient canthus, we can see the intercanthus has increased, whereas the IPD remains the same. So there is soft tissue displacement, which appears like there is a broader nasal, where opposed to where dacrus has increased, because of which the orbit itself is lateral. Coming to the next
In
pseudoproptosis.
the previous slide, is there any
Yes.
specific ratio of interpupillary distance and intercanthal distance, which is normal? Nilambika?
Yes, sir. Interpupillary, and it's almost
No.
in double.
X is the interpalpebral distance. Now, what is X?
Palpebral fissure.
Between the fissures, lateral and medial.
Yes, sir. Yes.
Canthus. That is the distance. So the same distance should be there between the two canthus.
Yes, sir.
Okay. So if it is more than that, then it is distinct. What? Hypertelorism. No, it is same, but intercanthal distance is more, but the interpalpebral distance is double. So then it is telecanthus.
Yes.
It's written on the diagram.
Yes, sir.
Okay. So basically, in normal anatomy, the distance between medial and lateral canthus is same as between two canthus, that is medial canthus of both eyes. Okay, so that is the normal symmetry. Understood,
Yes,
everyone, or no? Nilambika, did you
yes,
understand
sir.
what is
Yes,
written in? Okay. Okay, go to.
yes, sir. Am I audible?
Yeah.
Okay, sir. So coming to the next term, which is pseudoproptosis. So in case of enlarged globe, like myopia, trauma, or in glaucoma, in case of an asymmetrical orbital size because of congenital or a post-surgical retraction, then in case of asymmetric palpebral fissure, where there is contralateral ptosis or a lid retraction or facial nerve palsy, lid scar, ectropion or entropion, then in case of extraocular muscle abnormalities like post-surgical muscle recession, paralysis or paresis, and in case of contralateral enophthalmos, where there is a contralateral orbital fracture or small globe or cicatricial tumor. So the eye appears to be proptosed, but actually proptosis is not present. So differential diagnosis by laterality, unilateral, most common cause of unilateral and bilateral proptosis is thyroid eye disease. In case of unilateral proptosis, we may see infectious conditions like orbital cellulitis. There could be presence of developmental anomalies, inflammatory conditions, vascular anomalies, neoplasms, and metabolic disease. Bilateral proptosis includes orbital myositis, thyroid eye disease, cavernous sinus thrombosis, and metastatic neuroblastoma. So, by differential diagnosis by age, between the first 5 years of age, the most common cause could be it could be a dermoid, a metastatic neuroblastoma, rhabdomyosarcoma, epithelial cyst, glioma of the optic nerve, sphenoid wing meningioma, and hemangioma. Between 5 to 10 years of age, pseudotumor, orbital extension of a retinoblastoma, malignant lymphoma, leukemias, dermoid, and hemangioma. In 10 to 30 years, it could be a pseudotumor, a mucocele, meningioma, thyroid eye disease, lacrimal gland tumor, malignant lymphoma or leukemia, dermoid and hemangioma. 30 to 50 years of age, again, it could be similar conditions, but the likelihood of malignant lymphoma, leukemia increases. So over 70 years of age, the cause could be melanoma, pseudotumor, lymphoma, metastatic tumor, and mucocele. So, coming to the history and examination, there are 6 P's that we have to remember when we evaluate a case of proptosis. The first is pain, second is progression, then the third is evaluation of the proptosis, palpation, pulsation, and periorbital changes. So, coming to the first, which is pain. So, whether the pain is associated with rest, associated with any ocular movements, the distribution of pain, and whether it is constant or intermittent. So, in case of pain, it indicates involvement of the nerves. The branches of ophthalmic and maxillary division of the trigeminal nerve are involved usually. It could be because of an inflammatory process from an adjacent area, which is like thyroid eye disease or orbital inflammatory pseudotumor, also known as idiopathic orbital inflammation. Nerve infiltration by a tumor could also be a cause, like in case of adenoid cystic carcinoma of the lacrimal gland, scar, post-traumatic scar, or the pain also could be idiopathic. The next is progression, whether the onset is acute within days or subacute, that is weeks, or it could be chronic from months to years. The progression could be rapid or slow or indolent based on the time that it takes. Then condition with onset is if it is over days to weeks, it could be because of non-specific orbital inflammation, scleritis, myositis, dacryoadenitis, or infectious conditions like orbital cellulitis. It could be because of hemorrhage, maybe because of trauma, thrombophlebitis, fulminant neoplasia like rhabdomyosarcoma, neuroblastoma, and metastatic tumors, which have a rapid course. Then the progression occurring over months to years includes dermoid cyst, benign mixed tumor, neurogenic tumor, cavernous hemangioma, lymphoma, fibrous histiocytoma, fibrous dysplasia, or osteoma. So basically, conditions which are progressing over days to week, it is more of a inflammatory cause or a traumatic cause, maybe condition which have progressed over months to years are more probably benign tumors. Then we have to ask the patient for a past medical history. Thyroid history is very important because it is one of the most likely causes of the proptosis. Then any history of cancer or already detected. Then diabetes, HIV history. If the patient is on any medications like steroids or other immunosuppressants, social history, and then family history of any cancer or thyroid disease as it runs in families. Then review of symptoms, presence of any constitutional blue symptoms like fever, malaise, weight loss, night sweats, suggestive of a lymphoma or a leukemia. And other GI, breast, prostate, and endocrine systems have to be evaluated. Coming to general examination, we must look for signs of Graves' disease. Presence of cafe au lait spots could be suggestive of neurofibromatosis. Any malignant focus or infective focus has to be seen. Then coming to ocular examination, the head posture, the facial asymmetry, and ocular movements have to be noted. Usually, facial asymmetry is present in a case of unilateral proptosis. The ocular movements could be restricted in case of thyroid eye disease or maybe traumatic traumatic cause. The visual acuity is usually normal, but it could be diminished because of optic nerve compression or because of exposure, corneal exposure, so exposure related keratopathy. A patient could also complain of a diplopia, which is there, vertical or horizontal diplopia based on the globe position. Then refraction, the patient could have developed and could have acquired a hyperopia, maybe because of a mass indenting the posterior pole. Then checking of the IOP is important in case of thyroid orbitopathy or where there is restriction of movements, AV fistula, the IOP may seem raised. A differential IOP test can be done where there is a difference of 6 mm of at least 6 mm of Hg done in a primary gaze versus done in a gaze where there is a restriction of movement, which is known as a Brayley's test. Then conjunctiva has to be checked. Presence of chemosis. There could be presence of dilated episcleral vessels. Presence of which it could indicate a carotid cavernous fistula. Then presence of a salmon colored patch, which could be suggestive of lymphoma. Then coming to the eyelid examination, presence of lid retraction, lid could be there, lid lag could be present. An S-shaped lid is usually suggestive of neurofibromatosis. Presence of lag of thalamus should also be checked. So cornea could show presence of exposure keratopathy. Staining can be done to see if any epithelial defects are present. Then presence of Alish nodules is seen in neurofibromatosis on the iris, and pupil could show a relative afferent pupillary defect. Fundus picture may show optic disc swelling or optic atrophy. Optic disc swelling shows a recent compression of the optic nerve. Optic disc atrophy is usually following a long time. Then optociliary collaterals could develop, and choroidal folds can also be seen. So coming to incision, the protrusion of the eyeball can be seen through two different methods. One is the Knapp-Zieger's method, and the other is the bird's eye view. The first, which is the Knapp-Zieger's method, while the patient is sitting, the doctor could sit behind and just see tangential to the eye and hear that the eye proptosed, and it can be visible. Am I audible?
Yes, audible, please.
Okay. The second method of viewing is the worm's eye view, where the doctor sits in front of the patient and the patient looks upwards, and from the down view we can see that whether proptosis is present. Then while inspection also, we can look at pulsations. The pulsation usually indicates a vascular tumor, particularly those with an arterial component. Example, an arteriovenous fistula. It will pulsate and will also have an associated bruit. The next important direct proptosis, because the direct will indicate where it has usually arise. So an could be of two types. It could be an axial proptosis and abaxial proptosis. The axial proptosis usually indicates that the conal and intraconal part of the eye has been involved, like in case of thyroid eye disease, optic nerve glioma, optic nerve sheath meningioma, and cavernous hemangioma. Then coming to abaxial, proptosis of the eye in the downward and outward direction could indicate a dermoid, a dermolipoma, frontal and ethmoidal mucocele, and a meningocele. A downward and inward movement could indicate a lacrimal gland tumor or presence of dermoid. The upward movement could indicate a carcinoma of the maxillary sinus, lacrimal sac tumors, lymphoma, maxillary sinus tumors, or presence of any metastatic mets. Outward movement displacement could be because of a lesion of anterior ethmoidal sinus, nasopharyngeal tumor, lymphangioma, metastasis, secondary tumors, or presence of any midline granuloma. The medial displacement could be presence of a dermoid cyst, a lacrimal fossa tumor, and cyst. So the next thing we have to check for is the periocular changes, whether there are changes in skin color, whether there is swelling of the eyelid or any eyelid lesions are present. Tumors in the orbit often originate from a previously unrecognized skin tumor, so basal or squamous cell carcinoma, which is why the changes in skin color or any eye lesions are important. Lid edema could be indicative of an orbital mass or congestion from compression of the venous circulation or elevated pressure with the venous circulation within the orbit, which can be from a local congestion in the orbit or cavernous sinus or systemic, as in the case of pulmonary hypertension. Enlargement of the vessels on the conjunctiva may also be an indication of the same. The next, we come to palpation. The first thing we have to check for is retropulsion. Uh, we using two fingers, we try to uh, palpate the eyeball, and we check whether the consistency is soft or a firm consistency. Usually, if a soft consistency, it could be presence of a hemangioma, lymphangioma, or presence of orbital varices. And in case of firm consistency, it could be optic nerve glioma. A resistance to retropulsion is suggestive of a retrobulbar tumor or a thyroid ophthalmopathy. Then coming to orbital thrill or pulsation, we have to distinguish between true pulsation versus transmitted pulsation. When we keep two fingers over the eyeball, in case of true pulsation, along with the anterior movement of the fingers, there is also a little separation. Whereas in case of transmitted pulsation, only anterior movement is seen. Then swelling or mass around the eyeball has to be checked. We have to look for the size of the mass, then the site at which it is present, the shape, the consistency, the fixity to the skin, the muscles of the eyeball, and the bones, and signs of inflammation like rubor, color, dolor, and sensation, loss of function can be seen. Coming to regional lymph nodes, the preocular lymph node, submandibular lymph nodes. Usually, the medial two-thirds of the upper eyelid and medial one-third of the lower eyelid drains into the mandibular lymph node, whereas the lateral of the upper eyelid and lower two of the lower eyelid drains into the preauricular lymph node. So, checking of enlargement of the lymph nodes is important. We can also check for other lymph nodes like the postauricular, submental, upper, middle, and lower jugular lymph nodes. Then the orbital rim or the margins have to be checked. Insinuation of fingers is done to check for the any fullness of the orbital rim or presence of any irregularities or any tenderness which can be seen. Then reducibility is usually seen in cases of vascular tumors or schwannoma or varix. Then infraorbital and supraorbital anesthesia have to be checked using a cotton vest. So involvement of the nerves may cause an anesthesia or a paresthesia. Therefore, checking of the orbital sensations is also important. Also, reducibility of vascular tumors. We can see in case of a varix or a vascular tumor, if the patient is asked to look downwards for a few seconds and is bent forwards for a few seconds, and then come up, we can judge the level of proptosis. Then coming to auscultation, using the bell of the stethoscope, usually bruit is heard if there is presence of any AV malformation. Transillumination can be seen if there is a visible anterior if it is bright, it could be a cyst with clear fluid. If it is equal, it is usually lipoma. If it is indeterminate, it could be a cyst, inclusion or a dermoid cyst, and dark indicating aneurysm or a solid tumor. Then coming to measurement of the exophthalmometry, measurement of the proptosis by the exophthalmometry. So the first is Hertel's exophthalmometer, which is the most commonly used. Measurement from lateral orbital rim to the anterior corneal surface is done. As we can see, it is placed exactly at the lateral orbital rim of both the sides. It is aligned properly. Presence of a 45-degree base is present, and we can see the eye, which is seen clearly. We have to align it according to the red line which is present, and the amount of proptosis is noted down. Then the limitation is such that the readings are unreliable in presence of poor fixation in uncooperative patients with convergence and repeated head movements. The fractured lateral orbital brim also is a limitation for use of Hertel's exophthalmometer. Presence of fluids exophthalmometer, it is preferred in a case of facial asymmetry, and both sides the readings are present, and it is just a transparent scale-like structure where the readings start from the from the apex itself. So in both sides, it can be accurate. Then in Nogle's exophthalmometer, it measures the difference in progress. It is a superior and inferior rim-based instrument. So the next investigations where that we must do are include the thyroid function tests for presence of thyroid eye disease, CBC, and peripheral blood smear to see any presence of lymphoma, leukemia, or other conditions. ESR can be done to see if any inflammatory, to rule out inflammatory cause. A is for sarcoidosis. C-ANCA can be done. Then imaging includes non-invasive and invasive techniques. Like non-invasive include X-ray, CT scan, MRI, and orbital USG. And invasive techniques include orbital venography, carotid angiography, which are more important for vascular causes of proptosis. So this is the
What
general
are
orbital.
in thyroid? What is TPO antibody test?
Thyroid peroxidase antibody test.
So commonly done tests for thyroid are T3, T4, TSH.
Yes.
What
Yes.
are the what is the importance of each?
So usually T3 and T4 are raised in a case of hyperthyroidism, and TSH is low if it is a clinical hyperthyroidism present. So free as well as total T3 and T4 are also done, and these are usually found to be raised.
And TPO antibody. So thyroid eye disease is not just related with hormonal imbalance; it is also considered as a immunological disorder. So
Yes.
sometimes the thyroid status may be normal, euthyroid, but patient may present with thyroid or orbitopathy. Okay, so that
Yes,
is
sir.
called euthyroid orbitopathy. Okay, in such cases, sometimes we may have antibody test which is positive.
Yes, sir.
Oh, go ahead.
Okay. So, before going to the investigations, just a brief about orbital anatomy. Like I said, if there is axial proptosis, it is usually or a space in muscle there can be done of of any these can be seen as uh, uh, carcinomas. Then soft tissue changes can also be seen, but not very much appreciated. And orbital emphysema can also be very clearly seen. Then indications of an orbital of an orbital globe lid position and edema. Some cases disturbances, in cases of orbital there rise in intraocular pressure, edema, or atrophy and vascular retinal occlusion, choroidal orbital trauma. So, based on the mass lesion which is there, whether it is round or oval, irregular or displays and anterior margin. So, if it is round or oval in shape and has a smooth border, we look at the internal ego. They are more and strong with a mission and a compressibility present silicone. It is suggestive of venous hemangioma. Whereas there is this compressibility as other, it is present in the superior compartment. It is suggestive of dermoid. In presence in the lax tumor, nerve shadow, and a good sound, a defective wall, orbit wall, lipo, and optic nerve, it could be or so of an irregular, it could be along with presence of carcinoma, and it could also be a metastatic carcinoma. If it is an echo-free cavity and with a good sound transmissibility, presence of pulsatile motion, it could be a hemangioma, and a positional variation could indicate a varix. Then, if the anterior margin is clear-cut seen and there is a strong reflectability, it could be an is the gold standard for diseases. 2 cuts and 1 cuts for optical can be ordered. Contrast enhanced CT in inflammatory lesion, vascular tumors, osteogenic or chondrogenic sarcomas, and presence of metastasis are visualized. Normally, contrast enhanced structures in orbit are extraocular muscles and the lacrimal apparatus. Three-dimensional CT is typically reserved to assist in preparation for craniofacial surgery or repairs of the complex orbital fractures. Then, in case of a thyroid eye graves of the, we can see insertion remains normal. There is swelling of the organ, the muscle can also be here. Then presence of unilateral proptosis with lid edema in both eyes. And when you see the CT scan, we can see a left preseptal cellulitis and an axial CT showing opacification, which is present anterior to the orbital septum. So this suggests more of preseptal cellulitis as compared to this area where this picture where there is the axial CT shows preseptal as well as orbital opacification. So it is suggestive of orbital cellulitis. Now, with mild proptosis, which is present over here, axial proptosis, a bright lesion present in the corneal region is suggestive of an optic nerve sheath meningioma. Then lymphangioma with which is present more anteriorly, as you can see over here. Then rhabdomyosarcoma, we can see presence of the lesion here. Then in case of carotid cavernous fistula or any AV fistula, we can see that the vessels appear more congested. In case of a capillary hemangioma, we can see a small red lesion which is seen, and cavernous hemangioma is seen over here. So in cavernous hemangioma, it is one of the most common benign orbital tumors, and it's a vascular orbital tumor, which is usually, it could be intracorneal and affecting middle-aged women, which again progresses as a slow progressive axial proptosis. And on USG, we can see a well-circumscribed retrobulbous with homogeneous irregular ecostructure. Then final diagnosis of any mass could be assisted by fine needle aspiration biopsy and incisional biopsy or excisional biopsy. Usually, if it is an anterior segment mass, a fine needle aspiration biopsy can be done. An incisional biopsy should be usually avoided to avoid any tumor seeding. An excisional biopsy, if it is the entire mass can be removed, so it is also preferred. So orbital decompression, the indications being compressive optic neuropathy, presence of exposure keratopathy, and cosmetic reasons. The most common wall which is used is the deep lateral wall. The principle being the bony expansion, that is increase in the volume of the orbit, as well as the fat decompression. So soft tissue, decrease in the soft tissue. So coming to the summary, the causes of proptosis appearing after a history physical examination along with exam Pseudoproptosis ruled out because of a motility disorder or an enlarged lobe, any of lid retraction or content of thalamus. True proptosis has to be seen. A CT MRI of the lesion has to be done. If there is no marks present, it could be because of an inflammatory cause. The inflammation could be because of thyroid or respiratory syndrome, presence of like Wegener's or Bok-Straw syndrome, and an autoimmune cause which could induce pre-septal cellulite. A traumatic cause could no inflammation. If marked, it could be of infective colic, vascular mucormycosis, orbital thrombosis. Vascular include carotid cavernous malformation, AV malformation, papillary hemangioma, cavernous angioma, and an orbital varix. Metabolic causes could include fibrous dysplasia of sphenoid wing, Paget's disease of sphenoid wing, and neoplastic cause include lacrimal pleomorphic adenoma. Different causes, including lacrimal gland tumors or glioma, lymphoma, optic nerve involving tumors, or aptomyosarcoma, or bone involving, including osteoma, ossifying fibroma, and metastasis. So, based on the description of the proptosis, a presence of lid, extraocular muscle, belly enlargement, and soft tissue sign after ruling out thyroid eye disease. Then painless axial RAPD along with gradual vision loss in a female child with features of neurofibromatosis. It could be an optic glioma. If it is in a female middle-aged with a psammoma bodies, it is suggestive of optic nerve meningioma. If it is a painless axial proptosis along with gradual visual loss, it could be a benign intraconal tumor like cavernous hemangioma or schwannoma. An abaxial, which painless proptosis. It could be suggestive of lacrimal gland tumor, especially like this. If it is proptosis is directed downwards and inwards, and presence of abaxial painful with signs of inflammation could indicate an orbital cellulitis or pseudotumor or malignancy. Thank you.
Okay, very good. Go back to the second last slide of the. Okay, this is a exercise for all the students that you have to write this table. Okay, all the important differential diagnosis for proptosis. Okay,
Yes, sir. Yes, sir.
and go back to the first table where you have written the most common causes as per the age, I think. Yeah, this one. So these are the most common causes as per the age. So I want you like every cause for different age groups, what are the commonest causes? And as per the 6 P's, what are the features that you will see in each and every lesion? Okay, for example, dermoid, what are the 6 P's which are usually seen? Okay, so these two are for homework. All students have to
Yes,
write that. Okay.
yes, sir.
And you should know everything about thyroid eye disease because that is the commonest cause of proptosis which presents to us.
Yes, sir.
Okay. Any questions?
No, sir.
No? Okay. Okay then. Huh? Good this thing presentation. So next time I think you can have like in clinical presentation, if you have any case of proptosis or anything, you should present, or anyone can take a case of proptosis, present in brief. In clinical case presentation which we take on Thursdays, we don't need a lot of information in that, just the clinical case and its salient features. That is what we need. Okay.
Okay, okay, sir.
Okay, good. Okay, I will
Thank you,
end the
sir.
meeting now. Thank you.